Okay, I'm going to get started. I want to welcome everyone to our Bioethics Grand Rounds. My name's Thomas May. I am the Floyd and Judy Rogers Chair here at the Elson S. Floyd College of Medicine at Washington State University. We have two speakers today who are going to be talking about genetic testing of children and newborns. The first speaker we will have is Gail Knight. Gail is the Chief Medical Officer at Rady Children's Hospital in San Diego and one of the pioneers in the use of whole genome sequencing for pediatric patients. Our second speaker will be Aaron Goldenberg. Aaron is at Case Western Reserve University School of Medicine in the Department of Bioethics. He is the director of the Bioethics Center for Health and Genomics, and he has served on several national and international commissions on newborn screening. So we should have a very interesting set of talks here today. Next slide, please. Our Bioethics Grand Rounds is sponsored by our Certificate in Medical Ethics, which is offered in collaboration with Kaiser Permanente's Northern California Regional Ethics Program. We want to thank Kaiser for their participation in this as well. So if you have any information about that certificate program, you can follow the link here to find out more information about that program. Next slide, please. None of the faculty for this educational activity have relevant financial relationships with ineligible companies to disclose. Next slide. And if you want to receive CME credits for physicians, you can scan the QR code here or follow these steps. We will be posting these steps or a link to these steps in the chat toward the end of the session for you to be able to follow these instructions to receive one category, one credit from the AMA's CME department. Next slide, please. Again, please do not share the content of our speakers' presentations beyond this Grand Round venue and the posted recordings. And I will now get us started by turning over our speaker to Dr. Gail Knight, who will take over now and share her slides. Gail.
Hey, thank you so much. I'm going to pull these up. So thank you very much for having me. And this is an area that I'm particularly passionate about it. So for those of you, just to give you some background, yes, I'm the Chief Medical Officer, but I've also been a neonatologist here for the last 32 years. And then I went into administration 9 years ago. And the NICU here that I was in charge of for many years is the highest level NICU in our region. So we are the recipient of many complex kids here. So just to give you some information. And hopefully, of course, the slides are not going to move just because I was ready. As you already know, no disclosures, but the one thing I do want to disclose to you is that this is not going to be a talk where you're going to see a lot of data sets or bar graphs or any details about any publication. This talk is about hopefully bringing you into my world and the world of bedside clinicians as it relates to our journey through rapid whole genome sequencing and the impact. So the first thing, though, is I want you to bear with me for a few minutes because I feel like I just need to give you a little background about myself and why I am so passionate about the world of genomics. And while I won't go all the way back to the beginning, I will tell you that it really starts for me in about 8th grade when the first day of the science class with Dr. Dickinson, who says to the entire class that you will be doing a science fair project. And I don't give out A's, which were pretty much fighting words for me. I'd wanted to be a doctor pretty much all my life, as long as I can remember. And to say I was a geek is an understatement. My second home was the library. So I went promptly to the library, and that is where I fell in love with Watson and Crick. In fact, I now like have the original book from 1968 that I fell in love with because they had just gotten the Nobel Prize, excuse me, for the discovery of the structure of DNA. And I was just enamored with the whole thing related to DNA. So my science fair project was creating this structure, the double helix, and then writing a paper. So anyone in the audience or who sees this that was around in the late 60s or 70s, no matter how old you are, you would know about that picture of the couch in the upper right-hand corner. So that isn't my mother's couch, but that pretty much is what it looks like because that was a treasured vinyl covered couch. And when I built my DNA structure with the double helix, I could not get the helix to work right, no matter what I tried on the sides. And my mother let me cut up her cushions to use the vinyl to put that together. So the love of a mother is pretty amazing so I'm just very thankful that my mom knew how passionate I was and how important this was for me. But what happened was I realized as I was doing this that it really wasn't about trying to prove that I could get an A or the type of student. It was about this person right here. And this is my niece, Mona. So I'm the youngest of seven, and my oldest sister was 26 when she delivered Mona, and I was about 9 years old. So many of you now hear the term diagnostic odyssey. Well, I can tell you it is not new. Um, the experience of living through a diagnostic odyssey with a child has been forever. And I experienced that as a young child watching my sister, my brother in law, my parents struggle with trying to figure out what was wrong with Mona because she didn't eat well. Uh, all of her gross motor skills, as well as fine, were delayed. She didn't walk, talk until well past two. So for those 2 years, why isn't she sitting up? Why isn't she crawling back and forth to Children's Hospital in Los Angeles? Lots of tests, lots of blame, lots of stress on the family. So we were on that diagnostic journey. And it wasn't until she was well after two, when I was close to 11 or 12, that the diagnosis came. And I was asking Dr. May, and I don't know if any of you can put it in the chat or question, but if any of you can figure out from this picture, because I can tell you none of the tests help up until the end, if you can figure out her diagnosis. Today, it's very obvious, uh, but so what we were told was that she had Down syndrome. Uh, but up until that point, it was not even considered because they didn't feel like she looked like she had Down syndrome. So I couldn't figure out why she wasn't walking and talking and developing. Well, that was my introduction to what it means to be on Diagnostic Odyssey. But the important thing was when I discovered Watson and Crick and what they'd done, I put this together and I could understand what it meant to have an extra chromosome and not just Down syndrome, but to be trisomy 21. So fast forward to my first years as a junior attending here, what is now Rady Children's Hospital. And this is one of my first patients, Mitchell. So I was a diehard bedside clinician, and big baby respiratory failure was a lot of my research. So Mitchell was born at one of the outside hospitals. Mom, totally healthy pregnancy, fine labor delivery. And she delivered this beautiful big baby boy that was well appearing for all about 1 minute. Then he started struggling to breathe, turned very blue. The team tried to stabilize him, immediately called us, which we're about 15 minutes away from where this hospital, sent the transport team. Still, they could not get him to oxygenate in any reasonable range. So I had things prepared upon arrival here, but no one up until the moment he got here and later could figure out what was wrong with Mitchell. No reason whatsoever that this child should be this sick. This is his x-ray on the left. The one on the right is as close as I could get to a normal chest x-ray for a newborn because we don't have normal kids here. But the one on the left is Mitchell. And so immediately when you look at this, if you are a neonatologist or a pediatrician, you would think that's probably an extremely premature infant's lung because we call that ground glass appearance. And sometimes we call it whiteout. So, of course, people are thinking, okay, this must be pneumonia because he's not premature, but pneumonia doesn't look like this in newborns. It's patchy. And he didn't swallow anything we call amniotic fluid or meconium, which is baby poop. So there we were for all of a few minutes trying to figure out what his diagnosis was. But my job was to save this little boy's life. It didn't matter at that moment what the diagnosis was because Mitchell was dying. Mitchell was as blue could be. And so my whole world initially, as a neonatologist, was involved with ECMO. ECMO is extracorporeal membrane oxygenation. What it is temporary heart and lung bypass. So temporary heart and lung bypass, ECMO, does not fix anything, but what it does is buy you time. So the picture on the left is a baby that's actually going on bypass in our NICU, and this was right around the time when Mitchell was born. And so you see all the people that are involved. We've got the surgeons in the ICU, we've got scrub techs, nurses, neonatologists, everyone. And the machine itself, which you see on its right, it gets its own nurse all by itself, in addition to the nurse taking care of the baby. And in this particular case, Mitchell. And you could see a little teddy bear even under his bed. So ECMO certainly does have complications that goes on after a few days. But what it does is, again, within a few hours, we had him on bypass, cannula in the neck, in his aorta, and in his right atrium. Blood comes out, goes through the machine, picks up oxygen, it pumps back in. And then we try to figure out what's wrong. So we were hoping it was just going to be the typical ECMO course. Babies go on, just need some time for lung rest, and then they end up coming off 7 or 10 days, even sometimes with pneumonia or other types of things. But Mitchell wasn't acting like that. And because his x-rays looked the way it did, I was doing research with surfactant, and that is what premature babies are missing. So we gave him some surfactant. And within a few hours, it was like nothing was ever wrong with him. His lungs cleared up. He was awake. He was breathing. So I waited another 24, 36 hours before taking him off ECMO. And sure enough, after about 36 hours, when this artificial surfactant wore off, he was back to being in distress. We did this about 3 times. And then I remember something in residency where I'd had 2 kids over the course of 3 years that had similar courses and had passed away, and they were siblings. And I thought, this is so much like those kids. The only thing is, those babies, we didn't have artificial surfactant. So went on the journey of trying to figure out, did he have a surfactant abnormality? At the time, there was research that was done, and there was some surfactant protein abnormalities. So we did a lung biopsy. Dr. Nogi and John Hopkins, I'm still thankful to today, said it's not any surfactant gene mutation that I'm aware of today. But I agree that there's something to this. So we continued on the ECMO circuit route. Um, and then the surfactant worked less and less. We started to talk to the family about what the options were since we couldn't get them off. And that only option at that time was a lung transplant. Babies at that time was very hard to get a lung transplant, and many of them would die while they were on ECMO because of the heart transplants and lungs getting damaged while a donor child is waiting to donate the heart. So we gave them a boatload of surfactant and were able to get them off of ECMO. And what you see is Mitchell in his mom's arms. And that is a picture that is about 12 hours before he passed away, because once the surfactant wore off, then he could not support his own ability to breathe. But he got those hours with his mom and his dad in his arms. And so all I could say to Mitchell's parents were, I don't know the diagnosis, but I do think this is something hereditary, and I do think it has something to do with surfactant. Um, and Dr. Nogi still has the samples that we sent, and hopefully one day we'll figure out what that is. They did go on to have actually three more kids, and they sent me a picture. They moved out of town, and you can see that in my photo album, I have a little arrow pointed up where it says SP question mark BC deficiency. 10 years later, I got a call from Dr. Nogi, 10 years, and he said, I know what your patient has. And it was a surfactant protein mutation. But it took 10 years to figure that out. And I was able to call the family and let them know that it's autosomal recessive. At that point, they'd had three boys, three more, and they had decided that they were not going to have any more kids. But at least they now had a diagnosis. So let's move into 1990s, 2003, and 22. I'm sure most of you know about the Human Genome Project by now, so I won't go into it. And is it complete? We think so. But the more information we get, the more studies we do, who knows? But this has been a game changer for us, the completion of that Human Genome Project. You all know that there's publicly accessible DNA testing that people have access to, maybe not at the level of figuring out that someone has a surfactant protein deficiency, but it's amazing the progress that has been made. This slide I include because the head of our Genomics Institute loves to show this slide because it talks about the 2.8 billion genome positions and all that happens. And I say, you know what? All I care about, one thing on this slide, and that's at the bottom, is giving me a provisional diagnosis when you do whole genome sequencing. The other two interesting things on this is just how they end up coming with this provisional diagnosis, because you can do all that sequencing, but you need some other things for the clinician to be able to understand what is actually wrong with the patient. And that is where they use the EMR, whether it's Epic, Cerner, but they're doing this clinical natural language processing to pull out the clinical features. The other interesting thing from my standpoint was I completely forgot about this online Mendelian inheritance in man, and I just like saying it now. That number is far more than 5,000 plus diseases now, obviously, because we are doing whole genome sequencing and finding more and more genetic diseases, just like we found with Mitchell 10 years later. So I want to talk to you about now that we are well into our journey with rapid whole genome sequencing and ultra rapid, very different than a whole genome sequencing that you might get 6 weeks or in the past months later. So this is a NICU course 1 year before we had access to this. So this is a baby that started having seizures within a few hours of life, had all the typical seizure medication. We also did antibiotics, antivirals, just in case it was that, multiple genetic tests, metabolic tests, everything that could cause seizures. The other thing you'll see is vitamin B6, and essentially that is pyridoxine. And we do a pyridoxine challenge test. And we would joke that one day we're going to find a patient that actually responds to the pyridoxine challenge test. Uh, Unfortunately, like this child and many other ones before, is that nothing worked. And you have now a baby in your NICU that is seizing and seizing, and now you're 1 week, 2 weeks, 6 weeks, and left with neurological devastation from 6, 7, 8 weeks of continuous seizures until they burn out, or many of them passed away. And when I say many, you've got to remember I have a prior to this, a 25-year career, not including residency and fellowship. So the babies that would come in seizures that we could not support are more than the number of fingers that I can count on. So this is the impact of finding out a diagnosis 55 hours after baby presents in our NICU with seizures. So it turns out that Maverick, who did have a pyridoxine challenge test and did not respond to it, turns out that's actually was his diagnosis, a pyridoxine deficiency. So it turned out it was about the dosing. And some kids need a heck of a lot more. So he was immediately started at 55 hours on triple therapy with pyridoxine, L-arginine supplementation, and dietary lysine restriction. That's it. Just these three things, PO. His EEG immediately normalized, his seizures stopped. He was off all the other anti-seizure medication within a day and a half. We took him off the ventilator within a day and a half, and he went home within a few weeks, hitting his milestones at 7 months of age and continuing to do well. So this was one of the first cases that we had, and it really hit me at my core because I thought about all the kids that I didn't know a diagnosis and that I couldn't help. So to have this happen was incredible. And we talk about the cost of care, and I'm just going to just touch on it briefly. But you can imagine you've all seen an ECMO circuit and you know what it takes to put a child in ECMO in a course of a few weeks. Tons of money, millions of dollars, oscillators, special types of ventilators, dialysis most of these kids need. And I'm talking about kids in our ICU that we go down this diagnostic odyssey. Lots of invasive testing, medications, very expensive pharmaceuticals, subspecialists involved. And then there's the emotional cost and the duress and the stress on the family. And then quality of life for kids that do survive, but with a lot of challenges afterwards. There are definitely concerns, bioethics concerns, finding out that you might have a pre-existing um, condition and insurances. And then there's paternity, which can be a concern when you're doing whole genome sequencing, especially when there's not a lot of time to think about it. Now I'm going to talk to you a little bit about one of our PICU patients. 6-month-old, previously healthy, comes into our ED, gets admitted to our PICU with hypotonia, dehydration, was acidotic, lactic acid built up throughout his body, and was in hypovolemic shock. The only thing in his history is that he had 1 week of a viral URI illness, nothing significant URI. So his working diagnosis was botulism. We've seen this before, thinking was botulism. But by day 3, he had multi-system organ failure, heart, liver, kidney, respiratory failure. And I have to approve all the ultra rapid. And so I got this call. I'm like, absolutely. Unless you can guarantee me it's botulism, it's ultra rapid. So that's what they did. Turns out he had a mitochondrial disorder. And what we know in the literature is that the only thing that's out there is there's a case report of 2 families with the same type of disorder that this child had. And in one series of the 3 kids, 2 of them had died, and the third one who didn't die was not as impacted as the first 2 were, and the first 2 are very similar to our case. So now we have this little guy, and this is the from the family, happy, healthy, on a mitochondrial cocktail. Yes, has risk for metabolic crisis with illness, which is exactly why the child presented at 6 months because of that mild URI, developed that metabolic crisis. So it's followed by multiple subspecialists, but is doing very, very well. Our cardiothoracic ICU. So 14-year-old, again, previously healthy, athlete, Sat home, passed out. Luckily, the mom was there and she was in full arrest. The mom started CPR. Ambulance got there. They shocked her multiple times. On the way to the hospital, also shocked multiple times. Received CPR for more than an hour at the outlying hospital. And someone said, we keep getting her back. Let's call Rady's and just talk to them. We said, well, come get her. She arrived, again, full arrest, but we have ECMO. They were totally ready. Put her on ECMO. I don't need to go into ECMO anymore. You know, it's heart lung bypass. Gives us time to figure out what is going on. By now, we are well into, if we aren't 100% sure of a diagnosis, we're going to do ultra rapid whole genome sequencing. And even if we think we're sure, we're still going to do it because we have discovered that we don't know everything we think we do. So day 0 upon arrival, she had ultra rapid whole genome sequencing. And by day 2, we knew that she had this damaging variant that causes severe cardiomyopathy, unrelenting, and that her heart was not going to get better. And even if we could get her off ECMO with a lot of medications, that the outcome was still not going to be good. So she was listed for a heart transplant. She got her heart transplant on her 7th hospital day. She went home at day 22. And this is a few days after her heart transplant. And it says sign of teenage health because you see that she's texting her friends in the hospital after having a heart transplant. Um, so it's an incredible story that would be very different and has been different for many kids in previous years and decades. Project Adam, just going to briefly talk about it. Please, you guys, look up Project Adam if you don't know what it's about. But it's a teenager that collapsed from cardiac arrest on the basketball court and died. And the parents were adamant about if there was something that could be done differently to save other lives. Well, having an AED and knowing how to use it is one of those things where cardiac arrest does not have to lead to cardiac death. And AED makes an incredible difference. So we teach kids, and in this particular case, junior high and some elementary kids in high school, what to do if your classmate, your teacher, or someone else falls out. um, get the AED and use it while you call 911 or while someone calls 911, because it's the AED that can make the difference in long-term survival. Now, it isn't always a good story, a good ending in that sense. And I feel like I have to honor all of our kids, no matter what, and in particular ones where they don't end up making it. So I'm going to just let you know from the beginning. So that Dr. R is Dr. Rao, and he is our medical director of our cardiothoracic ICU. He also is the medical director of Project Adam. So I had actually forgotten to tell anybody that I was like, had gone on vacation to Disney World with my grandkids. And I'm on the plane and I get this text, 16-year-old, this is from Dr. Rao, it says 16-year-old sudden cardiac death on golf course, admitted last evening. Can you approve ultra rapid? I said, yes, on plane. Hope you get this. He said, thanks. I said, did they get an AED or at least CPR? He says, got both. However, he is very sick. And for Dr. Rao to say to me, very sick, I knew that this child already probably had significant complications from a prolonged arrest. So he says, I had to come home to first hug my son tightly. And I just said, yes, I'm sitting next to my 14-year-old golfing grandson who was wondering why I gave him a hug with an extra I love you. So they got the diagnosis several days later, and I got the text that says that it's positive for a mutation, possibly responsible for the cardiomyopathy. Very similar to the other teenage girl that we had. Um, but Jeremiah, unfortunately, the injury to all of his organs from lack of perfusion or oxygen was too much. Um, and so the family sent us these pictures, and this is from his memorial service, and actually they had it on their Facebook. But this is Jeremiah from baby up until the last picture as you go around. and you can see as siblings. So while we couldn't save Jeremiah, now his family knows that it was a hereditable disease, the cardiomyopathy, which means that they can make decisions about their family, Jeremiah's sibling, and themselves about getting tested and any other relatives. Um, so it's important to honor Jeremiah and his life and the importance to his family, and actually for our team that tried to help him. So, with that, I say thank you for having me, and hopefully, you can sort of understand the world that we live in on the side of taking care of so many babies and kids. So, thank you again, Dr. May, for inviting me.
Thank you, Dr. Knight. That's a wonderful explanation of the utility and some of the promise that is offered by advances in genomic technologies in this context. With that in mind, we're now going to turn the mic over to Aaron Goldenberg, who will talk about some of the ethical issues that arise in the use of genomic technologies, especially in the pediatric context and in newborn screening. Aaron, I will turn it over to you.
Perfect. Thank you so much. And thank you for that wonderful talk, Dr. Knight. That was fantastic and really points to the need for us to be kind of pushing the envelope in these technologies because of how life-changing they can be for families. Um, I'm going to talk a little bit about the kind of ethical, legal, social issues that are coming up as we start integrating genomics into other settings within the newborn time period, in particular, state-based newborn screening programs. Some of the themes around reducing the diagnostic odyssey, helping families to get kind of wider sets of information that might be helpful for their children, for future children, for kind of thinking about their own lives. Some of those same themes are kind of woven throughout these topics as well. So I think you'll see some connections. But I want to start by also kind of going back into history and in this case going back into the 1960s, where we see Robert Guthrie trying to figure out how to identify and address rare disease in newborns in time to get them into therapies that will be life-changing and life-saving for them. He also had a number of family members who were diagnosed with a number of conditions, including PKU. So, of course, which led to the original PKU test. And that motivated him to say, if we can just catch these conditions early, if we can get these kids into therapy early, we can change their lives, change the trajectory of their conditions, change the trajectory of the sequelae of those conditions, and really be a life-changing moment for them. So very quickly tried to figure out how to integrate genetic testing, or in this case, PKU testing as a start, into the post-newborn time period as early as possible. Interesting, a lot of people don't know this, that newborn screening was originally going to be a hospital-based system, but that at the time, the idea of having public health laboratories that could do PKU and then other kinds of tests at every birthing center in a state was just not really possible, which really led to the idea of a state public health lab taking over newborn screening. And this was revolutionary to kind of think about how to address these kind of large needs for population-based screening while knowing that it couldn't happen just in individual hospitals. And here we are 60 years later and celebrating, over 60 years of public health screening. And we're in a new generation. We're at a time where new technologies, new kinds of conditions are being requested to be added to newborn screening. And what I want to do today is talk a little bit about and kind of problematize the addition of whole genome sequencing into that setting and what that means for bioethics, what that means for families. So let's start by talking about the original legal justifications for newborn screening. So let's go back in time again, at this time to the 1980s. Newborn screening had been around for about 20 years, and many of our colleagues in bioethics had said, all right, Newborn screening has been around for 20 years. It's a mandatory program, so it's a compulsory screen. How do we go about making sure that that compulsory screen is justified from an ethical standpoint? So Ruth Faden and her colleagues decided to try their hand in 1982 at writing out a justification for public health newborn screening, in this case, PKU screening. And they came up with kind of three primary principles that I've used in my work over the last 20 years in newborn screening to kind of justify mandatory screening. The first one being the welfare, child welfare, something that we all kind of think about that, doing individual newborn screening benefits that child by identifying a condition early. The second principle is the harm principle, which really lets the compulsory nature of newborn screening. So the idea that parents, if they refused and their child had a positive result, significant harm would come to that child. Therefore, screening outweighed parental permission in this case, thus leading to, as we know it, compulsory newborn screening in this country. And then the third one, which is really important, is kind of the universal nature of newborn screening. The idea that every newborn has a right to access newborn screening, has a right to have that information, and that from an equity standpoint, we should not have disparities in access to newborn screening. Therefore, every child should have access to it. It keeps the cost of newborn screening low. It is covered by many insurances, including public insurance. Um, and so this idea of universal access is really core. And we're going to revisit these three at the end of my comments. So here we are in 2025, and we're now, this is so new. We've been talking about this for about the last 5, 10 years, but we're talking more explicitly about the integration of whole genome and whole exome sequencing into state newborn screening programs. So for those of you who may not know, newborn screening programs today are mostly metabolic tests that look for various analytes in the blood sample for the presence or absence of particular analytes, thus pointing to a genetic disorder. There are some conditions that have some areas of genetic testing that are done. Most of that genetic testing and genomic screening is done as a secondary or an adjunct to that biochemical marker. But now there's a lot of interest in moving towards whole genome sequencing as a potentially primary mode for newborn screening. And as you can imagine, this raises a number of ethical, legal, and social issues. What is the psychosocial impact of genomic information? How do we address issues of informed consent? How do we address issues of the kinds of information we may get? So adult onset, carrier information. What do we do when we want to return genomic results? Right now, parents only get their results back from newborn screening if they have a positive. So most parents don't even get any results back unless they go and they ask their pediatrician. If we do whole genome sequencing, different story. Lots of information coming back to families. How do we manage that communication? How do we think about privacy and genetic discrimination? We're not talking about just 70 tests. We're talking about potentially hundreds or thousands of pieces of genetic information. And how do you try to keep that information private at the state level, at the policy level? And then finally, issues of equity will definitely come into our conversations in terms of access to genomic sequencing and access to treatments afterwards. So I'll start with kind of what I think we all think about as kind of bread and butter ethics questions, which is consent for sequencing, right? Newborn screening currently has no consent process. So how do you go from a process that has no consent to potentially doing a full consent process for newborn genomic testing? Or do we need to? Should we be integrating whole genome or exome sequencing in a mandatory fashion in order to kind of maintain that level of universality? So there's a couple questions that have been raised. Should we have tiered screening? Should, for example, the regular newborn screening be mandatory while whole genome sequencing is a consented process? What do parents at the state level actually need in order to make that decision about whether or not they want that extra tier? How do we maintain the benefits of newborn screening if we add whole genome sequencing? So one of the concerns is if we add whole genome sequencing and parents don't want it, do you potentially hurt the whole program? Do you have parents opting out of newborn screening generally because they're worried about what may happen to their child's sample? And this again raises this interesting question, which is full consent even possible for genomic newborn screening? How do you do that at a state level for 30,000 births or 100,000 births or really 4 million births across the country? So we're not talking about a clinical genetics program where you're talking about a few hundred newborns. You're talking about every newborn. And how do you assure that that consent is done in a meaningful way? Um, so it's both about the complexity of the results and what do parents actually need. We also have to deal with the question of uncertainty. We know from other studies, I'm going to show a study in a second, that as you move from traditional newborn screening to genomic newborn screening, you can do things like reduce false positives, reduce false negatives, increase the accuracy and the kind of information families are getting. But we also know that it would increase uncertain results. So this is a study that was done in Virginia just a few years ago that looked at replacing traditional newborn screening with whole genome sequencing, specifically of the state's panel. And what they found is that it it did decrease false positives, which is a great thing. So it gave more accuracy to families, better information, but it increased uncertain results versus traditional newborn screening. So families received a much higher level of variance of uncertain significance. Um, and 88% of those were ones that were linked to a potentially dominant disorder, but without knowing whether or not the child might actually have the disorder. So one of the things that I spend a lot of time thinking about is what does this mean for uncertainty? How do families deal with getting uncertain results? And I have a grant right now with Beth Tarini at Children's National in Washington, D.C., to work with families over a course of a year to better understand what uncertainty means for them. How do they deal with uncertain information? And hopefully, maybe I can come back and present some of those data in the future. We will also have privacy concerns in newborn screening especially as we start doing more with the genetic information and genomic information at the program level. So there have been over the last few years a number of lawsuits towards state newborn screening programs about the handling and use of genomic data and newborn screening data. Two lawsuits in New Jersey, one in Michigan, one in Indiana, one in Texas, one in Minnesota, all related to the concerns around genetic privacy and what newborn screening programs do with their data. And so we know that there's going to be kind of evolving privacy concerns as we ramp up newborn screening towards whole genome sequencing. What are we going to do with the data? How do we make sure that we can create programs that remain trusted and trustworthy at the state health department, knowing that there's increased distrust of government agencies, increased distrust of potentially researchers and hospital systems. And so, how do you maintain those benefits of newborn screening that we just kind of have had for over 60 years as we evolve the program? How do we do that? How do we make sure that those benefits remain? So, as you can imagine, there's a couple of other things that we need to think about as we talk about the kind of bioethical implications of genomic newborn screening. So, we know we're going to be giving information at a much larger level to families than they currently get in newborn screening programs. And we need to think about how do we assess the psychological or psychosocial impact of that information on families. Are we increasing anxiety among families? Are we increasing potential psychological harm? Are we impacting family dynamics? Are we creating what has been kind of come to be called patience in waiting? So we give families lots of genomic information right at birth about conditions that their children may have in the future or may not have in the future. And we create what some families may think of as just a waiting for their disease to happen or waiting for the disorder to happen. How do we try to give enough information to families that is helpful, that is useful, but at the same time doesn't create that idea of a patient in waiting? We have had for a very long time in bioethics, many of you probably know this idea of the right to an open future. The idea that we don't give later onset or adult onset variant information to families because we want those children to make those choices at themselves as they grow older. That kind of the idea of a right to an open future has kind of been a part of kind of genetics and ethics really since I was a student, 25 years ago, and kind of is remains today. But I will say, and I'll go back and forth a little bit. I will say that as genomic information has evolved, our considerations within the kind of bioethics community have evolved as well. And we've thought about the idea that maybe we need to be kind of thinking about parental rights to access to genetic information because of the possibility of preventative future actions. And maybe we need to think about new ethical, and I have, LC questions here, ethical, legal, social issues that say maybe a right to an open future is still an important aspect of how we think about genomic information in families, but maybe we should weigh that with the best interest standards. And maybe we should start thinking about now that we know we can give families a lot more information at birth about variants that might be later onset or even adult onset, should we be rethinking that right to an open future? And that's kind of an interesting set of questions for us to kind of ponder together. I also just want to say that, fears of genetic discrimination and stigmatization based on genetic information has not gone away. I do a lot of work within communities, and every conversation I have, especially around the idea of increasing the amount of genomic information that families may be getting, especially from government agencies, raise lots of concerns around genetic information and genetic discrimination and stigmatization. GINA, the Genetic Information Non-Discrimination Act, is a wonderful law, but has a lot of loopholes, right? So GINA protects you if you work for a larger company, but if you work for a small company, may not protect you. If you work for a government agency, may not protect you. If you are looking for long-term disability insurance or you're looking for life insurance, not covered. And so one of the kind of other increasing ethics questions as we start thinking about whole genome sequencing and newborn screening is, do we have to reignite the conversation that we were having in the mid 2000s to think about how do we address potential discrimination or stigmatization based on genetic information? How do we do that together? I want to get to a couple issues around equity, and for me, one of the largest questions within bioethics right now is how do we continue the work that we want to do in supporting questions around equity. And newborn screening is one of those places that I think we need to have this conversation frequently, and really kind of bring it to the forefront. So right now, we can say with some certainty that every child can access newborn screening. It's one of the benefits and one of the really successes of the program. It's universal. How do we maintain that universality if we start moving towards whole genome sequencing? If costs go up, if insurance coverage changes, if clinical centers can't handle doing the sequencing, how do we maintain that universality? And how do we do so in a way that assures that that genetic and genomic information not only can get into the hands of families, but that interpretation, support, genetic counseling, all the things that we all may talk about can continue for an exponentially larger number of families receiving information. We also need to think about equity beyond screening. So let's not just talk about access to the screening itself. That's great to think about screening, but what happens after? What happens once families get that information? So how do we make sure, for example, that families get access to the follow-up services they need? Availability of follow-up doesn't always mean accessibility. So we need to think about disparities in follow-up. So here's a chart. Here's some data I've worked with, New Steps, Association for Public Health Laboratories, that looked at post-screening access to diagnosis and post-screening access to interventions. And what this data has found, this is very early data from this data set, is that non-white families received their newborn screening information at about the same time as white families. But if you looked at average time to diagnosis and average time to intervention, for non-white families, those took place between 2 to 3 weeks later than white families. And we might say, well, 2 to 3 weeks, that's not such a big deal. But for the conditions we're talking about in newborn screening, 2 to 3 weeks may be life and death. So the idea of a delay and a disparity between access to care is one that we have to worry about even in today's newborn screening. And I will just put up, warning lights at a much higher level once we start talking about genomic testing and genomic screening. And one of the questions that I ask in a lot of my work is, what are our obligations to provide access to care? If we start moving towards whole genome sequencing, what are our obligations beyond just getting access to the sequencing itself? What are our obligations to care, to follow-up care, to diagnostic processes, to treatments that might be incredibly high cost? Maybe you all have been following this, but some of the really miracle gene therapies that are coming out for a variety of newborn screening programs are amazing drugs, but can cost families upwards of 1.5 to $2 million per dose. Those costs are coming down for many of those drugs, which is fantastic, but there's a lot of variability in coverage for those drugs, variability in insurance coverage, variability in Medicaid and Medicare coverage across states. And so we might set up a system where a child could access particular services if they're born in one state and not access those in another state. Maybe not so new for the healthcare system generally, but something that we would really kind of, I think, push against from an equity standpoint in newborn screening. I want to end with just a couple of quick slides to talk a little bit about the fact that, there have been changes since the 1960s. So the idea of mandatory screening, mandatory testing, which really made a lot of sense in 1960, doesn't always mean it's going to make sense now. And that doesn't mean that I'm saying we shouldn't have mandatory newborn screening. I think we just need to have a conversation about whether or not societal changes, for example, like the questions around how samples and data are handled and trust in institutions that handle samples and data, things raised by, for example, Henrietta Lacks's story, concerns about who has your information. So this is a t-shirt of a child saying, "Help, the government has my DNA." This was one of the plaintiffs in one of the lawsuits. And we also know that there's a much higher impact of advocacy. So NORD and Every Life Foundation that do a lot of advocacy trying to increase newborn screening, which I think is fantastic, are changing the way we think about stakeholder values, stakeholder views within the context of newborn screening. And I think the work that we do must reflect those societal changes. We need to raise questions of, do those original ethical justifications of newborn screening hold given these societal changes and the technological changes that we're talking about? Also, I want to just say that for me, I also think there's a false dichotomy that sometimes is talked about in newborn screening. Like we have to somehow balance parental permission versus benefits. Like kids will only benefit if we have mandatory screening. And I think what we need to be doing is thinking not about this as a dichotomous variable, but how do we maximize both? How might we maximize parental permission for sequencing and maintain the benefits that have been really helping families for over 60 years? This is one of the things I hear a lot, which is pushing back on the idea of changing newborn screening because it just works. This idea that compulsory screening, just works, and why would we mess with that? And I think genomics, adding genomics, at the very least, should give us an opportunity to question that, to put that into a new light. So my last slide, I just want to say that I think if we go back to Faden's original ethical justifications, child welfare, harm principle, and universal access, I think we need to put those into a genomic era and ask whether or not genome sequencing necessitates thinking about expanded notions of benefits and potentially expanded notions of harms. How do we think about those long-term and short-term harms to families? And how do we create a much wider lens of equity across an entire newborn screening system that may now include whole genome sequencing? Okay, well, I want to end there so we at least have a couple minutes for questions. This is my daughter getting her newborn screen. She's older now. She gets very embarrassed when I use this in my slides. But thank you so much. Looking forward to hearing your thoughts.
Thank you, Aaron. We've got a couple of questions, and I'll go right into them since our time is limited. The first question that we have for either of you, if you want to talk about this, about some of the ethical issues that would arise if genomic screening was done instead of at birth, but early in pregnancy when termination is still possible. The technology, it says here, is the technology would be similar, but the ethics would be very different. Would either of you like to comment on some of the issues that might be raised in that context, or might arise in that context?
I think, Aaron, you'd probably be the best, although I've been in that situation where parents have asked specifically for that reason, but I love
Yeah,
to hear.
I'll just say very quickly, thank you. I mean, I think the answer is yes. I think we have to be thinking across the perinatal spectrum. We have to be thinking about the idea of adding, particular kinds of conditions or genome sequencing into the prenatal time period. We tend to silo those two conversations. Even in bioethics, we have our prenatal bioethics folks and we've got the newborn screening bioethics folks, and we never tend to talk with each other. And I think what we need to be doing is having more conversations across the perinatal spectrum. For families, it is a spectrum. It's not like all of a sudden they think differently once the child, is born. It's a dynamic that covers all the way from preconception, prenatal, newborn screening, early pediatrics, late pediatrics, and we need to be really thinking about genomics across a life course. Does that mean that it raises new ethical issues, whether it's about termination, whether it's about other kinds of, prenatal considerations? Yeah, it will. But I also think that A, it's worth having that conversation, and B, I think there are ways that we can address that. So, for example, there's been a big push for third trimester whole genome sequencing, which would avoid some of those questions. But I also think it's okay to have these larger questions about, how do the ethics change in the pre-postnatal setting? Um, Increasingly, we're finding that some of the conditions being proposed for newborn screening, even if you get that information earlier, you can't get the kids fast enough into treatment. And you can't, so kids who maybe need a stem cell transplant or need other kinds of, um, having that information prenatally may be incredibly life-saving because you'll know ahead of time to get that child into the protocol as soon as they're born, rather than potentially waiting 5 to 7 days to get that newborn screening result back. And
Yeah,
so I do think it's worth thinking about this idea of a spectrum of sequencing across a pre-postnatal time period.
yeah, particularly for many of those metabolic disorders. So from the minute they're born, before they're symptomatic to, yeah, it's
100%, 100%.
Second question here, Dr. Knight. Dr. Goldenberg talked about a lot of different obstacles to the uptake of genomic technologies or expanding newborn screening, for example, uh, in terms of whole genome sequencing. Uh, in whole genome sequencing in general for pediatric patients, we have privacy concerns, we have rights to an open future concerns, we have reliability concerns, trust concerns, and cost concerns. Uh, could you say something about what you see are the biggest challenges in expanding whole genome sequencing
um,
in that context, or is it mostly just cost?
and great talk, Aaron. I just that you hit everything. So to be honest, right now, our biggest barrier really is cost. Even for those insurance companies or other systems that know that it would be beneficial. And again, we're currently even dealing with high risk patients that have a higher incidence of having a treatable disorder. It really is the cost, and as the cost comes down, just like it did with many of the other testing that we're doing with newborn screening. I'm hoping that that will not be the major barrier, but to be perfectly honest, the major barrier really is cost and knowledge. Once you have access to this and it's a tool, just like looking to see what if someone's anemic or not, it is hard. It's very hard for our trainees to go to a place and not have access to this. So
All right, we have hit 1 o'clock, so I'm going to have to cut off the questions. If someone has a question they would like to have answered, if you could email it to me, I will try to get that question to the speakers and get an answer for you. Again, if you are interested in claiming CME credits, uh, you can check the chat box for instructions about and a link for how to claim those credits. I want to thank both of our speakers for wonderful presentations. I think we got a lot of information and a great understanding about the human sort of aspects of the utilization of genomic technologies in this context. So thank you both Dr. Knight and Dr. Goldenberg. We I want to thank everybody for attending, and keep your eyes open for our announcement of the fall Bioethics Grand Rounds. So thank you very much. And with that, I will end today's session.
Thank you all so much.
Thank you very much.